तो उसकी उम्र 86 years हो जाएगी just because of 10-year delay coming 2025. So, I mean, that's the buffer zone that they keep, and they keep on looking at the evidence that comes, the new evidence that comes. So, we have a couple of stark changes, and since I'm dealing with undergraduates here, I'll try to focus on those core issues which would be relevant for your exams as well. So, guys, the first and the foremost thing which I want to bring to your notice is that every time you're going to come across a pulseless and a BP-less patient in your casualty, you might be thinking of various possibilities, and one of them, apart from asystole or cardiac arrest, is going to be a pulseless electrical activity. Now, every time you read this word, PEA, pulseless electrical activity, what are the things that you should, I mean, what are the things that should be going on in your mind apart from the possibility of asystole? Understood that a person can be going on, he could be developing a cardiac arrest, that's okay. I mean, the ECG will be showing a flat line primarily, but what are the reasons why a person could be having pulse electrical activity are again all the way very important for everybody to know. So I'll just summarize this by saying 3 points. I mean, in 30 seconds, what is your thought process when you are in your intensive care unit or you are in the casualty of your, let's say, government hospital with limited amount of facilities? Because we are starting, I mean, the facilities might be even better. But back home in India, Pakistan, we have limited facilities available. So and obviously there's so many patients that you need to do fast thinking so that you can analyze and you can give a correct treatment to your patient. So one of the important things I think that really matters. Okay, thank you, sir. Thank you for the kind invitation. I missed that message. Okay. One of the very important things that I think every doctor should be keeping in his mind are these words of mind. That is, every time you see a patient who's pulseless, BPLS in the emergency, you should think in terms of possibility of ASS2, but apart from that, you need to think in terms of is it an empty heart? I'll just explain what I mean by the word empty heart in a while. Then you need to think in possibility of empty lungs in a patient. I'll just explain what I mean by the word empty lungs or collapsed lungs. And at the same time, I can say another reason why, or let me put it another way, there could be pressure on the heart or pressure on the lungs. Let me just jot it down and then I'll explain the 4 points that I'm trying to say. That every time you're getting a patient who's having a pulseless electrical activity, what is your thought process? Empty heart, empty lungs, pressure on the heart, pressure on the lungs. Now, what I mean by the word empty heart is like, let's say a patient patient was stabbed, right? Lots of time in our casualties, you might be having gunshot, you might be having a stab injury. So if a person is presenting with hypovolemic shock, if a person is having a requirement of massive blood transfusion, the heart is still beating. I mean, why I'm calling this an empty heart is because the heart is still beating, but it's actually empty because all the blood is draining out. If there's a large vessel being damaged in a patient, and I have picked up this image mainly to sensitize you to the fact that a stab injury to the chest, very common with violence, gang violence, especially in tier 2 cities, both in the subcontinent. You could be having a patient who's having one attention pneumothorax, and second he could be bleeding. He could be having hemopericardium, that's okay. He could be having a hemothorax, that's okay. But he would also be having blood loss. So there would also be hypovolemic shock occurring in the patient. So every time you're getting a pulseless or a BPLS patient, one of the differentials that must always be kept is hypovolemic shock, which would imply empty heart, and because this is a treatable condition. See, you need to differentiate. I'll tell you also how to differentiate, but first and foremost, you should be knowing what are the differentials in any crashing patient. The differentials in any pulseless BPLS patient, the first differential to be considered is asystole, cardiac arrest. That even a non-medical can understand. But you guys are technical people. What I want you to think in terms of is one is empty heart, hypovolemic shock, because in this time we're going to be putting a white bore cannula and rush and give massive blood transfusion to a patient. So most of the time, if you've taken a advanced trauma life support training, a ATLS training, you will be putting a orange cannula in a patient. That's the widest mode available. In case a doctor has not taken treatment or a doctor has not taken training for putting a orange cannula, then in the emergency scenario, you can be putting in a gray cannula and you first be starting crystalloids, but your orders would be MTP. That's a massive transfusion protocol, which is to be followed in this particular case. And lots of time, in your vivas, in your exam, they're going to ask you like, what is massive transfusion protocol? I mean, how many units of RBCs, how many units of fresh frozen plasma, how many units of platelets are you going to give to the patient? So your standard answer would be, because nowadays we don't give blood right, because we are using blood components. So your standard answer is gonna be that I'm gonna be giving 6 units of RBCs, we're gonna be giving 6 units of fresh frozen plasma, and we're gonna be giving 6 units of platelet-rich plasma. Please remember, this 6 units of platelet-rich plasma is equal to, listen to the words very carefully, it is equivalent to 1 unit of single donor plasma. SDP. Single, one is PRP, that's made from pooled donors, and that is single donor platelets, which would be produced by the process of apheresis. So the message here is 1:1:1 is the ratio that would be followed. And for any patient having an empty heart, it's a treatable condition. We can prevent death of this patient definitely. So one of the differentials that must be considered every time you're having a patient who's having a pulseless electrical activity would be empty heart. Now, apart from empty heart, what could be another possibility? Empty lungs. What I mean by empty lungs is that a person could be, let me say, this patient has developed a deep vein thrombosis. There's a clot developing in the soleal veins, which is embolized to his right side of the heart. It will go from the right atria to the right ventricle to the pulmonary artery. It's going to block the pulmonary artery and it's going to cause pulmonary embolism. And pulmonary embolism, the movement that happens, the circulation to the lungs is going to drop to zero, and if the circulation to the lungs is going to be hampered, then if there's no blood supply to lungs, no blood going to the lungs because there's a big saddle embolus, there's going to be crashing of the blood pressure because after all the blood that coming in the right side of the heart has to go via the lungs to the left side, and if we are having a saddle embolus, it will cause crashing of the blood pressure of a patient. That would be empty lungs. That's going to be pulmonary embolism. So just put that up in a separate slide at the moment. I just described before you an important term that you as a doctor should be knowing. Every time you get a pulseless electrical activity, that is an empty heart, that's hypovolemic shock, large vessel injuries, it could be gunshot, it could be a stab injury. Then is empty heart, empty lungs. What I mean by the word empty lungs is that the patient of yours could be having a pulmonary embolism. There's a big clot blocking the pulmonary artery. In fact, at this junction, I would like to say that though we are almost through the Delta strain of COVID-19 that was causing mayhem and was causing pneumonia, but I think all of you as doctors are aware of the fact that COVID is a hypercoagulable state. We lost a lot of patients of COVID-19 not because of pneumonia, not because of ARDS. We lost a lot of them because they developed either pulmonary embolism or they developed MI. Why they developed clots in the coronary artery, why they developed clots in the pulmonary circulation was because COVID is a hypercoagulable state. You would remember we were doing D-dimer assay in all of those patients. Why? Because COVID was a hypercoagulable state, so pulmonary embolism was causing death in a large number of patients with COVID-19 who suddenly in our intensive care units were becoming pulseless and BPless, and we were finding that those patients were having big clots expanding the pulmonary artery on an echocardiography. So empty lungs means pulmonary embolism, and empty heart here means a hypovolemic shock. Why we are studying this is because these are decisions, these are important events that must be recognized by any physician working in an emergency setting because these are treatable. For hypovolemic shock, as I said, you're going to give a massive transfusion to a patient, followed by, crystalloids obviously because blood would not be available in the emergency immediately. But if it's going to be a chap with pulmonary embolism, you're going to do a thrombolysis and you're going to be using LTEPLS in a patient. So two differentials of a pulseless electrical activity that every doctor should be knowing is empty heart and empty lungs. That's going to be hypovolemic shock and pulmonary embolism. Once we are through, then we talk about the aspect which is pressure on the heart and pressure on the lungs. Let me first, evaluate or explain to you what do I mean by the word pressure on the lungs. The technical meaning of the word pressure on the lungs would mean that a person could be having a tension pneumothorax. The moment you read the word tension pneumothorax, that means that the lung of this patient has collapsed. This could be a penetrating injury to the chest. Like a couple of guys, they went to a discotheque, they had a fight with a bouncer, and the bouncer stabbed them in the chest with a knife or any pointed object. Or gunshots, very common nowadays. I mean, a lot of these young chaps nowadays, just to show off their wealth and power, they might be carrying these small Beretta revolvers or pistols, and they just might shoot somebody from a very close range. And the end result of this close shot, gunshot injury is going to be the moment the bullet goes into the chest, there's going to be a tissue valve created. This tissue valve will behave like a one-way valve. It will allow this tissue valve will behave like a one-way valve, and what it is going to cause is collapse of the ipsilateral lung. So as you can notice in this diagrammatic representation, one, the ipsilateral lung of the patient will collapse. the movement, absolute lung will collapse. There would also be a mediastinal shift in a patient, so the trachea is going to be deviated. The apex feet of the patient is going to be pushed contralaterally. I mean, normally, like in this particular case of any particular, I mean, if the bullet injury is occurring on the right hand side, then apex feet normally is going to be in the fifth intercostal space 2 centimeter to the mid clavicular line. You will have a gross displacement of the apex feet, which you could be finding even pushed up to the maybe the anteraxillary line or even up to the mid axillary line. Plus, an important point here: why the patient is going to become pulseless and BPLS is not because of the bleeding. Yeah, gunshot injury is going to cause bleeding, but what causes that instantaneous crashing of the blood pressure of a patient is because the positive pressure here is going to crush the superior vena cava. The positive pressure here is going to crush the inferior vena cava, and this crushing of the superior and the inferior vena cava is going to result in a drop in the venous return. I mean, I can just say like this: the venous return becomes zero. If the input to the heart is zero, the output from the heart will also be zero, and this will explain why tension pneumothorax causes a pulseless electrical activity, because the heart is beating, but it is not getting blood because SVC, IVC will be would be compressed. The technical term that I want you to remember at this junction is obstructive shock, and this is again important for any physician working in the emergency room to know, is because of the fact that in obstructive shock there is no rule of IV fluids. There is absolutely no rule. In empty heart, I was saying that IV fluids have to be given, massive transfusion protocol has to be given, but in obstructive shock, there is no rule of any IV fluids. So in that 30 seconds, when the patient comes in the casualty, your mind is racing. Is he having an empty heart? Is he having an empty lung? Or is there a pressure on the lung? Now, how as you as a doctor are going to find out whether a patient is having an empty lung is that you're going to auscultate this guy, and on this particular side, when there's going to be collapsed lung, you are going to hear absolutely nothing. Air entry is going to be absent. There's going to be absent air entry. There's going to be absent breath sounds. I mean, normally we always hear we hear vesicular breathing. In this particular case, there's going to be no breath sounds, no air entry present on that particular side of the chest. And therefore, once you clinically identify this is a tension pneumothorax in a patient, you obviously plan X-ray for this guy, but he may not make it to the radiology department. So what are you going to do? In the next 15 seconds, 30 seconds, what's going to be your order to save the life of this guy who was stabbed in the chest outside the discotheque? Or let me say, this guy, he was shot in the chest, maybe a tier 1, tier 2 city, criminals roaming freely nowadays, and these guys carry these imported pistols and revolvers. The bullet was fired from a distance. Luckily, the bullet velocity was lesser, and sometimes these guys use bulletproof vests with the high velocity bullets. They can pierce through the bulletproof vest, and this guy will be hit in the chest. Lots of time our soldiers get hit in the chest in spite of having bulletproof vest. That's because of the high velocity caliber, the high velocity bullets and high powered rifles being used. The American M16 or the Kalashnikov AK-56. I mean, usually we get casualties because of that. So in those scenarios, what are you going to do for this particular patient where there is a pressure on the lungs? What are you going to do for this particular guy? Why I'm saying pressure on the lungs, because there is air and positive pressure. You see, atmospheric pressure is 760 millimeters of mercury. And the intrapleural space, the pressure is going to be something like -2 to -6 centimeters of water. I'll say that again. 760 millimeters of mercury, 1 atmospheric pressure. Intrapleural pressure, -2 to -6 centimeters of water. Huge difference, man. Huge difference. The air is going to rush into the chest, collapse the lateral lung, and there's going to be absent air entry, absent breath sounds, crushing of the SVC, crushing of the IVC, and the BP is going to crash right before your eyes. In this pulseless patient, what you're going to do, you are going to put a white bore needle. Where are you going to put this white bore needle? There are 2 points that I would like to say. One, you can put this white bore needle in the second intercostal space, or you can put it in the fifth intercostal space. Now, how to decide? Let me say a guy, he has big pectoral muscles. He's a very muscular guy. In a very muscular guy with big pectoral muscles, like a soldier, they do so much of push-ups and sit-ups that they'll be having big pectoral muscles. So when you try to put a needle by the second intercostal space, the needle may not reach the intended space that's into the pleural cavity, and you will not be able to do a needle decompression. So what are you going to do in this particular case where you have a male soldier with big pectoral muscles, or let me say there's a bulletproof vest already present? The bullet went through the bulletproof vest and the soldier is injured. So you gonna raise the arm of the soldier like this because bulletproof vest is in the front, bulletproof vest is in the back, but not on the side. And you're gonna count the number of intercostal spaces in the fifth intercostal space in the mid axillary line. That's where you're gonna do a needle decompression in a patient. So I'll just move to my subsequent slide, guys. Every time you are having a patient tension pneumothorax, what is gonna be your intervention? Your intervention is gonna be a straightforward needle decompression. Obviously, we need to put in a chest tube. We need to put in an intercostal drainage tube in the triangle of safety, but that's going to take a while to be done because you need to give a call to the surgeon if you're not yourself capable of putting a chest tube. But the decision making has to be fast, that if it's a chap with tension pneumothorax, a needle decompression has to be done. According to the latest guidelines, the preferred space that you should be accessing is the fifth intercostal space in the triangle of safety. Or instead of fifth intercostal space, you can also use second intercostal space. This would be a little lateral to the mid-clavicular line. In fact, the guidelines are like this. With respect to a child having tension pneumothorax, the recommended space is the fifth one, and for adult is fifth intercostal space. Though you can use any one of them, he says, depending upon whichever is the experience of the doctor, he can do that. But I told you practical issue. Practical issues like a nail with big pectoral muscles, you will not be able to go by the second intercostal space because of the bulk of the pectoralis major muscle. Or if there's a bulletproof vest in situ, then again, the getting the access would be a problem. So you can raise the arm of the soldier and you can access that in the fifth intercostal space. So tension pneumothorax is again a condition which is responsible for development of pulseless electrical activity. So there are four important differentials. I repeat that again. Four important differentials for pulseless electrical activity. Empty heart, that's hypovolemic shock. Empty lungs, that's a pulmonary embolism. The scenarios for pulmonary embolism can be deep vein thrombosis, any hypercoagulable state. Hypercoagulable state could be after pregnancy. In fact, I can just give an example. Serena Williams, I think all of you follow tennis. Right, Serena Williams, one of the fittest female athletes. She had a hypercoagulable state. They did not mention that in the media report. What is the hypercoagulable state? I suspect it could be factor V latent mutation. But after her delivery, she developed pulmonary embolism and her BP crashed. And the doctors in America had to rush to manage a pulmonary embolism. So why I'm telling you that example is because pulmonary embolism can occur just very suddenly in people who look very fit. I give example of the fittest female athlete, tennis player Serena Williams, who post her delivery because pregnancy is a hypercoagulable state. You all know that. So Serena Williams post her delivery, she developed pulmonary embolism. Though they were obviously able to take good care of her, but what I'm trying to tell you here is that pulseless electrical activity is something that can occur any time in career of any doctor. So every time you are in a casualty, you're getting a crashing patient. Apart from these, told three differentials have been taught to you. So now come to the fourth one, which I would rate that as one of the most difficult ones out of all of these to diagnose and manage. That would be pressure on the heart. So before I write down the condition that is going to put pressure on the heart, I want you to memorize these facts once again with me. Empty heart, hypovolemic shock. Empty lungs means pulmonary arteries blocked. That's a salpingo pulmonary embolism. Pressure on the lung from outside, positive pressure, tension pneumothorax. The fourth differential, the last one to be remembered, guys, is pressure on the heart. And this pressure on the heart is going to contribute, or it's going to be caused by cardiac tamponade. Cardiac tamponade is again common in India and in Southeast Asia because people drive cars without seat belts, and most of the time the cars that are available in our country, lots of time they do not have airbags. I mean, abroad it would be criminal for any company to be able to sell a car without an airbag. But in India, you will notice, or in Southeast Asia, you will notice that companies are charging a premium for the airbag. So people tend to purchase the lower model, which is without an airbag, just to save a few thousand rupees. But they pay a price for this because if there's going to be a car accident, if a guy is not using a seat belt, if in any case of a car crash brought to a casualty, if the seat belt was not being used by the driver, I want to tell you the fact that as little as 60 kilometers per hour, as little as 60 to 70 kilometers per hour, if the brakes are applied suddenly, the momentum would be such that the chest will move with the speed of the car and get slammed into the steering wheel, and this can result in cardiac tamponade. So I'm not talking about those fancy, Porsche or Corvette kind of a car. I'm not talking about, those cars that you see in Fast and Furious movie with all the safety features present. I'm talking about something very primitive, very basic, a Maruti 800, a Maruti Alto, all those common models, Suzuki, in Pakistan would be selling those models which do not have safety features. Same in India. They'll sell those Maruti Suzuki will sell those models which are gonna fail the safety features, and this is gonna contribute to a lot of time in our and because lots of time on our highways, no, there's gonna be the illumination of the highway is not gonna be perfect. So there could be a truck stuck up bang in the middle of a highway. This guy is driving fast 70 kilometers per hour. He doesn't see that truck bang in the middle of a highway. He rear ends it, the chest goes into the steering wheel, and that can result in cardiac tamper, and the patient will become pulseless and BPLS. And this patient obviously will require echocardiography for evaluation. But what are you going to do with this guy? You're going to do a quick echocardiographic guided pericardiocentesis, and that should be able to save a life. So my objective of today's discussion was mainly to sensitize you to what exactly, I mean, though there are a lot of steps in ACLS, I've not gone into those steps. I first want you to get into the thought process of what could be wrong. I mean, why is the patient pulseless? So what you have learned today is one reason why a patient is pulseless is because this guy goes into asystole. There could be various reasons for a guy going into asystole. He could have had a myocardial infarction. Myocardial infarction could have resulted in ventricular fibrillation. Now, for some time, myocardial infarction, so common in Southeast Asia, is going to trigger a ventricular fibrillation in a patient, and right before your eyes, a patient is going to collapse. So, I mean, what I've shown here before you is a BFib, then there's a development of an asystole, so we have a proper management for it. But this particular chart, guys, I want you to remember in your mind a mind map that is to be created for any crashing patient. What are the 5 differentials that have to be remembered? It could be asystole, it could be a hypovolemic shock, it could be pulmonary embolism, tension pneumothorax, or it could be a cardiac tamponade that is occurring in a patient. And I think if you get these differentials right, then at least some chunk of advanced cardiac life support activity becomes oriented. You get an orientation for that. Because CPR we all learn. In fact, in medical, they teach us about chest compressions and rescue breaths, so I didn't talk much about it. I didn't talk about adrenaline. Yeah, obviously, I mean, adrenaline is important. I didn't talk much about amiodarone, lidocaine, all those drugs. I mean, you guys are studying that in pharmacology as well. But what I'm trying to focus here is those core issues which are missing in the thought process. Because when you're giving chest compression, you are having so much of sympathomagnetic stimulation yourself. You know, you're all pumped up in trying to save somebody's life that our brain tends to become a little frozen, and that can result in a possibly manifestation. I can just quickly take a picture. I would really love that and request the host to send me across a picture of all the brilliant, lovely doctors that I'm interacting with today. Okay. Coming back to the core issue, it would be really nice if you can just send me maybe a 15-second clip of these young doctors who have decided to not scroll on social media but come and listen to an old man and listen to the technical aspects that I'm trying to explain. And these are the 5 days. Every time you're going to be dealing with a crashing patient in your casualty, and there are a couple of steps also that I would have loved to talk about, but I think Limit gave it to me at the moment. And Dr. Safillah, thank you so much for giving me this opportunity for interacting with these young doctors, and I'm really, really thankful to a lot of hard work that you have. I may not be knowing your names or
thank you so much, sir, for joining us. There are all the students from
interacting with you guys. I really appreciate this fact that I got this opportunity, and I was able to teach something which might be useful to you in your future practice.
Thank you so much, sir. Thank you so much for your precious time that you have dedicated to us, and inshallah we will see you in the future also. And again, thank you so much from all the secretary and the parliament and all the organizers of this conference. Thank you, sir.
Thank you, sir. Thank you, sir. Thank you, sir. So this was Professor Dr. Deepak Marwah, the one who doesn't need any introduction. We all are very aware of him. The Pratt faculty academician, founder of Deepak Marwah Medicine app, author of Deepak Marwah Medicine book, Maulana Azad Medical College, All India Institute of Medical Sciences, AIMS, and he spoke about the recent guidelines and updates in advanced cardiac life support. Thank you so much, sir. Up next, we have Miss Tasneem Nazim, Department of Biotechnology from the World Academy of Science.